Greetings to my fellow surgeons. Hi, this is Dr. Simanchal Goel. So, this is a comprehensive guide to your quick SICS. One should always have SICS in your armamentarium because I always say, it is the safety net for those difficult situations, those rexes runouts, those impending lens drops, those PC ruptures, and those calcified white cataracts, those elderly patients in which you cannot afford to lose that critical endothelial cell count. All these scenarios, when you consider phaco to be unfit for the patient, SICS is a very good procedure. I'll be sharing only the golden tips and tricks that have been very rewarding for me. This is a very quick SICS, and the special part about this SICS is I am going to switch to a zoomed out view for you all to see what's going on. And so, yes, we have started with the conjunctival peritomy. 3 steps that generally residents are fond of is to apply abridals, to do cautery, and at the end to place a suture on the tunnel. I am not going to do all these 3 things. I have just straight away did a peritomy, no bridles. I am creating a tunnel. This is the most critical part of an SICS to make a very good self-sealing tunnel. I have, mind you, created an inverted frown incision that is around 2 millimeters away from the limbus, which gives a very good valve formation. At the end of the surgery, I won't be needing a suture. And yes, you have to glide inside the scleral layers and the corneal stroma. As you all are aware, 90% of the corneal thickness is made of stroma, and you have to glide like a swan glides in the air. Your crescent should be a very high quality, sharp crescent that glides, separating the layers of stroma and separating those scleral layers also. Once you make a tunnel on a taut eyeball, then you can enter the anterior chamber. That is the golden tip number 2. You should not make a tunnel after you create these sideboards, because a hypotenuse globe is a big no-no for a good corneoscleral tunnel. Just going with the standard steps, staining the anterior capsule. As you can see, the patient is 80-year-old, and yes, the patient had calcified nucleus, and here you go. I have switched my Zeiss operating microscope to a lower mag. This is a wide field SICS because I wanted you to see the tiny details. So the surgery looks even better in this field of view. And just for your knowledge, I am operating a case. This is first case of my lifetime when I am operating it on such a wide field on a low mag like this. So because I have years of experience, I was able to just go ahead with the surgery. But you can be a little uncomfortable while performing a surgery in such a low magnification, but nevertheless your experience is going to pay off. So yes, the things to learn are about the rexes now. I'm creating a decently big sized rexes because we have to prolapse this nucleus out of the bag. In these cases with hard cataracts like these, the rexes size really does not matter as far as you can transfer the patient from hand movement to 6x6, So yes, we have completed the rexes. I was suspecting these calcified lakes with anterior capsule just sticking its way to the anterior part of the lens, but yes, the rexes has been doing good so far, and we are going to, here you go, we have entered the main tunnel, and as you can see, I've entered the anterior chamber in the going ahead in the clear cornea and then entering the anterior chamber. This is very important. If you make a premature entry, you are in for some really good troubles. All along the surgery, the iris is going to bug you and haunt you like a ghost. So never ever create a premature entry. And yes, I'm doing not a lot of hydro, but small little spurts of normal saline, and I prolapse one pole of the nucleus out. I'm going to inject visco, and as soon as you inject visco, one pole, the iris is going to depress and the nucleus pole is going to flip out easily. And here you go. Now the dialer will do its job. I'm going to just nudge the nucleus beautifully into the anterior chamber, and yes, now the whole of the brownish whitish, this this lens that has been accommodating all the patient's life, at least for the first 40 years of the patient's life, is now in the anterior chamber, ready to be replaced with a beautiful transparent acrylic IOL. And yes, the blood is oozing out at this point. I generally ask my OT assistant to just wash it, but he's too engrossed in this surgery and he's looking at the TV screen, and boom, this is the most satisfying part of the surgery, when you just take this biconvex lens that is impeding the flow of photons from the beautiful world that we see to the retina of this patient. And yes, I take that dirty brownish Coca-Cola color nucleus out of our line of sight and concentrate on the cortical remnants that are there in the anterior chamber. They'll be coming out of the anterior chamber in no time, just with simple visco expression. So visco in these cases is your truly best friend, because it has a lot of tamponading effect on small blood vessels that go on oozing blood. Because I have not used any cautery in these patients, there will be minimal tissue damage and minimal scarring, almost nil astigmatic effects on the cornea. So yes, in the other surgical videos you won't catch this glimpse, because you can even see my fingers, the latex glove, the IA cannula, the handle of the cannulas. You can see the sand blasted tip of my aspiration cannula as well for a good PC polish. And yes, we are in for a beautiful outcome. And I have not done two usual steps, the bridle suture, the cautery, and at the end I'm just going to place an IUL without a suture on the main tunnel. This saves you a lot of time. The operative time of this video was around 9 minutes, and I've sped this up a little for you. And you're going to just implant. There was some troubles that I was facing. The patient is having a lot of positive vitreous pressure in this. Like, the patient was anxious, was giving me a positive vitreous pressure. Nevertheless, the IL has gone in the bag. A beautiful surgery has concluded. Yes, I'm just hydrating the side ports, and I'll just close the conjunctiva over the tunnel without a suture. And that's all from my side. This was a beautiful, fun, small SICS video for my international audience, because this is one such surgery that safeguards your presence as a surgeon on the OT table. That's all from my side. I hope you like my stuff. Kindly like, share, and subscribe my stuff on YouTube. And thank you. Have a great day ahead.